Good afternoon. My name is Kay Oberhausen, and I am the Assistant Dean for Advancement at the UIC School of Public Health. It is my pleasure to greet you this afternoon and officially welcome you to our ethics lecture. This endowed lecture was named in honor of Professor Daniel Swartzman, who retired from the School of Public Health as an emeritus professor of health policy and administration after serving for 36 years as a faculty member at the school. During his tenure, he served as a mentor and friend to many students and faculty members through the years and left an indelible mark on the fabric of our school. The Daniel Swartzman Public Health Ethics Lecture is funded through the generous support of alumni and friends whose gifts made it possible for this lecture series to exist in perpetuity. I'm thrilled Professor Swartzman will join us to say a few words.
Thank you, Kay. All I have to offer is thanks. And there's so many people to thank. To Dean Giles and the School of Public Health, which was my home for, as you heard, decades. To our keynote speaker and our panel. It's just an honor that you are here participating in this with us. There was a core group of my former students who pulled together and started the campaign to endow this lectureship. It was a relatively small group, about a dozen, and I really thank them very much. And then on top of that group, there were many people who contributed to making this lectureship possible in terms of an endowment, and I'll help you out, Kay. I hope you keep supporting this so that it every year or every 2 or 3 years has this kind of impact on the dialogue of public health ethics that the School of Public Health is going to be a leader in. And then finally, the largest group that I had to thank is all of my former students. And I figure it's a couple of thousand people. And one of my current colleagues at Loyola, when I was talking to them about my work in public health ethics, asked me, who were my colleagues at the School of Public Health? And I said, well, I had a lot of colleagues, but actually there wasn't anybody that I was working with on public health ethics. It turned out that my real colleagues were those students sitting in front of me who were good enough to listen to my thoughts, who contributed their own thoughts to the discussion. And now I know there's this large group of people who are trying to lead meaningful lives in protecting public health because of the thoughts that I started with and that they contributed and that we shared in that process. So I thank all of those people. I'm just so honored to be here. Thank you so much.
Thank you so much, Professor Swartzman. We're honored to have you with us today and to have this lecture endowed in perpetuity. We're thrilled. So this year, the title of our event couldn't be more timely. As we are now seeing the rollout of COVID-19 vaccines across our country, we are very honored to have Dr. Helene Gayle with us today to present. Before I introduce our dean, who will be introducing Dr. Gayle and serving as today's moderator, I want to take a moment to share a few housekeeping items. So this presentation is being recorded. It will be available to watch at a later date, so please consider sharing the recording with family, friends, or colleagues that you think would enjoy it. If you have questions during the presentation, feel free to enter them into the question and answer box. So there is not the chat box you've been using right now, but the Q&A box. We will be getting rid of the chat box at some point. We will facilitate Q&A at the end of the event, and we are going to try to get to as many of the questions as we can. So the Q&A box, please feel free to enter those at any time as you have questions throughout the event. Without further ado, please join me in welcoming Dr. Wayne Giles, who is Dean of the UIC School of Public Health. Prior to joining UIC in 2017, Dean Giles spent 25 years at the Centers for Disease Control and Prevention, where he led many divisions and research activities during his tenure. Welcome, Dean Giles.
Thank you. Thank you, Kay, for that nice introduction. It's great to be here. And Dan, I want to again congratulate you and the huge impact that you've had on multitudes of students across multiple decades. It's really impressive to see the impact that you've had. So I do want to welcome our alumni, students, faculty, staff, and friends. We had over 500 people who registered for today. So you all are in for a great treat this afternoon as we hear from some truly incredible, well-esteemed public health leaders. I want to take a moment to introduce our three esteemed panelists who will join us later in our conversation. And I'm going to be very brief in their introductions because I want them to be able to spend their time talking and for us to discussing the issues. But I encourage people to check out the website for their few bios. Our first panelist will provide a national perspective. She is Dr. Julie Morita, who serves as Executive Vice President at the Robert Wood Johnson Foundation, the nation's largest philanthropy dedicated solely to health. She is the former commissioner of the Chicago Department of Public Health, and she recently served as a member of the Biden-Harris Transition Team COVID-19 Advisory Board in her personal capacity. She is also, we are also very proud to have Dr. Morita as an alumna of the UIC College of Medicine, and I think you were also a commencement speaker for the School of Public Health a couple of years ago. Our second panelist, who will provide a state perspective, is Dr. Ngozi Ezike, who became the director of the Illinois Department of Public Health in January of 2018. Many of us in the state of Illinois know her from her daily COVID briefings with Governor Pritzker. Today was a very busy day for her because earlier today she received the Solutions Foundation Excellence in Public Service Award presented by the Civic Foundation. Congratulations, Dr. Ezike. She was also the School of Public Health commencement speaker in May of 2018. We appreciate her support in that regard as well. And then providing a local provider perspective is Dr. Lee Francis. He is CEO of Erie Family Health, a community-based healthcare system that serves over 82,000 patients in 13 locations across the city. We're thrilled to have Dr. Francis as an alum of the School of Public Health. And we'll be hearing from all of our panelists later in the presentation. It is now my pleasure to introduce Dr. Helene Gayle, who is our esteemed keynote speaker today. Dr. Gayle has been president and CEO of the Chicago Community Trust, one of the nation's oldest and largest community foundations, and she's been president and CEO of the organization since October of 2017. Under her leadership, the Trust has adopted a new strategic focus on closing the racial and ethnic wealth gap in the Chicago region. As if that isn't enough to make her qualified to speak with us today, it is her role as co-chair of the Framework for Equitable Allocation of COVID-19 Vaccine Committee for the National Academy of Medicine that truly makes her an expert on ethics of vaccine allocation. I want to thank you for joining us today, Dr. Gayle, and for kicking us off with your thoughts. I want to start off talking about sort of how the framework came together. And I know NIH and CDC both sponsored the work of the framework. Can you talk a bit about sort of the membership on the framework and some of the ethical issues that were discussed during your deliberations?
Thanks so much. And before I say that, let me just say, first of all, I wish that I had been a student of Dr. Swartzman. Clearly, he was a wonderful mentor and teacher. I also just want to say thanks to UIC. My first ever commencement speech was for the School of Public Health. And if anybody has ever given a commencement speech, and many of the people who are on this have, still find it the most intimidating of speeches. You know, you have to be short, funny, and inspirational all at one time. And so I have a fond space in my heart for UIC, who gave me that chance to start my first ever commencement. And also just to say how honored and humbled I am to be listed as the keynote speaker, because any of the three panelists that you mentioned could equally be so. And so it's great to be at a panel of such wonderful, brilliant colleagues. Let me just say, when I go back and read the report that we wrote, it now all seems to make perfect sense. It seems to be laid out logically, reasonable framework. But when I think about where we were in July of last year, when we didn't have a vaccine, we kind of knew what candidates were most likely, but we didn't know a lot about where we would be in the epidemic. We didn't know how effective at those days. We were talking about a vaccine that might be 50% effective. We'd be happy if it was 70%, et cetera. There were so many things that we just didn't know. And so, I say that to say that, we started out by thinking about ethical principles, because in the midst of that much uncertainty and where we were at the time, we felt it was important that we started with a foundation of principles and values to guide where we went with this framework. And we talked a lot in the very beginning about what was the nature of this epidemic. And every epidemic has its own unique character. And I think that the ethical principles that one uses ought to be matched to the characteristics of a particular epidemic. And so when we stepped back and thought about this pandemic that had disproportionately impacted communities of color, that had disproportionately impacted the elderly, that had disproportionately impacted frontline workers, and that it was the first public health crisis in our lifetime that had caused an economic crisis and caused us to shut down whole economies and whole societies, that we needed to think about all of those things when we thought about the ethical framework. And so, we came up with a set of 6 ethical principles that we thought guided and fit this particular epidemic. 3 that were particularly focused on the ethics and our values. So we talked about maximum benefit. A pandemic that had such societal as well as health impact, we wanted to have the maximal benefit. We also talked about equal concern. And again, when you think about who was most impacted, everything from the fact that it had such a huge impact on the elderly. And oftentimes we think about, the number of years that you could preserve. Here, we thought almost in reverse, that it wasn't about the number of years you could preserve, it was that each life had equal value. So this notion of equal concern, also the issue of mitigating health inequities because of the disproportionate impact. And then we also thought about what were the procedural principles and ethical frameworks that we need to think about as we looked at the implementation of this, because of a lot of the ways in which science had been almost discarded, the way that there had not been transparency around the development of the vaccine. So we talked about fairness in terms of procedural values and ethics, transparency, and being evidence-based. So those were the 6 kind of ethical and procedural principles that were, really foundational in our thinking. From there, we really wanted to look at if we wanted to come up with a framework, what was the right way of thinking about risk? Because at the end of the day, what a vaccine does is to buy down your risk of disease and transmission. And so we looked at 4 different risks: the risk of acquiring, the risk of transmitting, the risk of negative societal benefit, and the risk of severe morbidity and mortality. And it was from those ethical principles coupled with those that risk hierarchy that we came up with our overarching framework, that came with the phases from phase 1 to phase 4 that we now all talk about.
So talking about that, I mean, I was wondering, in your deliberations, did you think that we would have the vaccine shortages that we're now seeing? And was that part of the rationale for the phases? And can you sort of walk us through what those 4 phases are as well?
Yeah, right. So, what we were asked by CDC and NIH was to look at an equitable allocation framework in the face of scarcity. Because with this pandemic, everyone should have the vaccine once it's available. But we knew that the demand would be higher than supply in the beginning. And so we needed to think about allocation of a scarce resource. And the scope of work was to do this in a way that was equitable. And I think putting equity at the center of it, again, given the characteristics of this particular pandemic. So when you look at the risk framework, look at the values and the ethical principles that we laid out, we came up with the 4 phases, with the idea that starting with a phase 1, rolling into a phase 2, rolling into a phase 3, rolling into a phase 4, and that you go through those phases as rapidly as you can based on supply. And that within each of those phases, there was no real hierarchy, that a phase, if you were in phase 2, by the time you get to phase 2, that would be timed with the supply so that anyone who was eligible in that phase would have access. The only phase where there was a bit of hierarchy was phase 1, where we had a phase 1A and a phase 1B. Phase 1A was healthcare workers and frontline responders, partly because we knew that the most likely first vaccine would be one where facility-based application administration would be more likely because of restrictions, the logistical restriction, extreme refrigeration, et cetera. The other part of the phases that we, and then the phases went from, highest risk of those 4 risks on down to the whole population, anyone who resided, regardless of legal status, et cetera, anyone who is in the United States should have access to the vaccine, and the phases rolled through accordingly. And I'll go back to some of the nuances of that, but let me just say also, across all of the phases, again, because equity was such an important part, we said that there should be priority given to the geographies that were high on the social vulnerability index that CDC created. The social vulnerability index being the 15 factors that really look at what makes communities vulnerable for disease or disasters, things like income, language ability, race, ethnic status, transportation access, et cetera. So we really wanted to prioritize those geographies, again, with the idea of mitigating some of the inequities, really prioritize those geographies that were high on that social vulnerability index. Just to go back to the phases again, I think, part of what, again, guided our thinking, and these are the kinds of issues that have come up since, for instance, in our phase 2, we have prisoners as well as people living in other congregate settings. Well, many people have said, why prisoners? They broke the law, they don't deserve it, and again, this gets back to this notion of equal regard. Prisoners live in a congregate setting, are unable to protect themselves because of living conditions. Their life has equal value and equal concern. And so these principles were woven throughout how we thought about these essential workers. We're talking about some of the people who are your grocery store attendants, the people who are in the meat packing business, people who in societal sense may not have the status of somebody, who works in a white collar job. But the reality is the jobs they serve are for our benefit. They have less ability to protect themselves, to wear protective PPEs, to distance themselves, to have taken into consideration some of the things, work from home. And so we wanted to make sure that as we thought about these phases, it really both adhered to the values and the ethical principles, but also to the risk framework, and that we were true to that framework in the way that we thought about these. And if you were high risk in any of those 4 risk categories, that's what got you into the phase, not your status in society, not how people might have thought about you relative to others. And I think that was what we tried to hold ourselves throughout as we thought about creating those phases.
Thanks for that. And I want to get to something that you alluded to in your last response, but that is, we are now in the midst of, here in Illinois, we're in what, 1B. But looking back from through deliberations back over the summer, are there things that you wish you had included in the framework or done differently as you think about this, or your thoughts on that?
Yeah, I don't know that there's anything, given what we knew at the time.
Yeah.
Not sure that there was anything that I would say differently. I think there's some points of emphasis. So for instance, there's a lot of discussion around equity from the standpoint of this is the right and the fair thing to do. And I think it is the right and the fair thing to do. Communities that have been disproportionately harmed as a result of it. People who don't have the ability to work from home and protect themselves. All of those things make sense. But I think what we didn't emphasize enough is that it's also the best from the standpoint of public health. We always know that you go where the risk is highest. And there's been a lot of discussion around let's get as many people vaccinated as possible. And while I believe that that is important and we want to get to as high a level as possible, if we're vaccinating people who are sitting at home, not in contact with others, not at risk, and those are the ones who have greatest access to the vaccine, we're not doing the best that we can as public health practitioners. We're not going where the risk is highest. And so I think what's the fair and the right and the just thing in this case also happens to be what is best from the standpoint of controlling a pandemic and doing what's in the best interest of public health.
Thanks for that. That's great. And I want to bring back our other panelists to sort of open it up to the largest group so you all could show your screens. That would be great as we begin to move forward with this. And I want to get at sort of one of the things that I think is the quintessential questions in public health, and that is to dealing with this issue of me versus us. And I think you get at this. And so how do we create a society where we're doing better at sort of balancing the me versus us? And I think as I think about COVID and the last 8 or 9 months we've been dealing with, whether we're thinking about wearing masks and that sort of thing or vaccinations, it's frequently questions about me versus us. So I want to open it up to the panel, and Dr. Gale, I think you can weigh in as well, but thoughts about sort of how we move into sort of a society that benefits or values all of us as part of this work. So whoever wants to start first. Phil.
I can jump in first. I think Helene did a fantastic job describing the interconnectedness between all of us, that all of us are dependent on our grocery store workers, our manufacturers, our first responders. We have this dependence upon each other. And I think it's really important to lift that up, because when you recognize that, then it's not so much me versus us, it's a recognition of how closely we are related to our neighbors, to our families, to people that we don't necessarily think of as having a personal connection with, but we are still very dependent on them. And then when we see the disproportionate impact that are on some of these folks who can't necessarily do the work from home, don't have access to PPE, aren't able to have sick leave or access to healthcare services, all these kinds of things really make it clear that taking care of everyone is really essential for all of us to be healthier and to thrive. And so I think, as Helene pointed out, it really this sense that we have to lift that up and make that clear so that people really can see it, because it's things we take for granted on a day-to-day basis.
Yeah,
I would- Go ahead.
No, I think it's been well articulated by both Dr. Gale and Dr. Morita. There is a certain culture that is present in our country that may be slightly different from other countries. And there are pros and cons, obviously, to some of the different parts of our culture. I know when I talked to my counterparts in South Korea, I was looking at like, how are they doing so well? And they were saying when our equivalent of the Surgeon General comes on and says, masks will help the community, everyone just says, okay, and I was like, oh, well, so, there are some strengths of our society, like rugged individualism, which are a thing. And it's one of the great things that has made America so amazing in certain ways. It just doesn't work in a pandemic. It doesn't work in a pandemic. And so trying to pull out some other parts of the culture that would help explain what thinking of your neighbor first, or thinking of your neighbor as yourself, or loving your neighbor as yourself, you have to show those examples like Dr. Gale showed about how you really aren't going to advance the needle. You're not really making progress if people who have no exposure to others are not getting the vaccination. So showing those examples very concretely is the way to go, because the prevailing rugged individualism isn't the principle we want to work on in this setting.
Boy, you took the words right out of my mouth there, Dr. Ezike, and to a certain extent, Dr. Morita and Dr. Gale, thank you for your presentation. I think the ethical principle, when I hear rugged individualism, I go back to this ethical principle that's foundational, and that is autonomy. And I think in our society, in the United States, we highly respect autonomy. In fact, from a public health standpoint, we overvalue it. We overvalue autonomy, and we say, well, okay, I get to decide when and how. I'll either wait to see how other people react to the vaccine, or I want to be first, or I decide how I'm going to sign up, or I decide if I'm going to wear a mask or not, if you pointed out. And as I think at the community level, it's a great example of a conflict between the ethical principle of autonomy and beneficence, which is doing good. What we want to do in public health is we want to do the most good for the most people. Yet we have autonomy, I'm going to, go my own way. And I think we see this time and time again with the issue of COVID vaccine, that these principles of ethics they pull against each other. They push and pull against each other. And it's, I think, up to us in the public health community to help our societies understand where to put the priority when there's two ethical principles in conflict with each other. We, of course, want to put the priority on beneficence, which is doing that good for society, and not everyone sees it that way. And there's a lot of other conflicts that we can talk about too, and I know that they'll come up in our discussion here on the panel.
Okay, Dr. Gale, did you want to add something?
Well, I was just going to say the flip side of that, or I guess the optimist in me does believe that this pandemic is making people think somewhat differently about public health and this trade-off between myself versus society. And I think there's a phrase, and I'll probably say it wrongly, but it's change occurs when the pain of staying the same is greater than changing. And I think we're at that point where the pain has been so that I think it is forcing us to think differently. And I am heartened when I hear people say, well, my turn hasn't come up yet, and I'm actually going to wait my turn.
Mhm.
People who could jump the line, if you will. And so I think people are starting to get it. And I think that the more we can keep building those lessons in and use this as a teachable moment, if you will, I think that we can perhaps have a different way of thinking, understanding that we are going to be our unique American selves, but that there is an opportunity for us to think a bit differently about what does it take when you face a threat as great as we're facing now.
I was going through my questions and I noticed a question in the chat or in the Q&A, and I just want to remind people in the audience to, if you have questions, to feel free to put them in the Q&A box. But there's one from Linda Ray Murray who was a question I was going to ask, but she actually asked it much more eloquently, which says, many in public health are concerned about hoarding and purchasing a vaccine by rich nations. What should be the approach of the USA in addressing the needs of the global South? What impact does failing to address vaccinations at a global level have on the duration and the intensity of the pandemic? So sort of a global, not but a national and a global perspective on this.
Yeah, and thanks for that. And I will just say from the standpoint of the committee, and we did address that. And part of our charge was, in fact, to hopefully have a framework that could have global utility. And we had a specific recommendation on the US and its commitment to the rest of the world. And, I think it's clear to all of us that we are not going to control the pandemic here if we don't really contribute to controlling it around the world. This is a global pandemic. The idea that we could make ourselves safe and create a national bubble is just lunacy. And so I think not only for our own self-interest we have to do it. And I also, again, when we were doing the report, we didn't know who was going to come out with the first vaccine. And suppose the first most effective vaccine had not been linked to an American company, and we had cut ourselves off from COVAX, we had cut ourselves off from the World Health Organization, we'd be in a bad shape. So, in the report, we actually recommended that there be a certain amount of vaccine that the US reserved to be able to give to other nations. But that said, it's obviously still going to be a challenge.
I'd agree with Helene. I think that there's other examples of public health threats that we have to take. We've clearly taken serious efforts, put in serious efforts to eradicate or to eliminate things like measles, things like polio, things like Ebola. It's clear that we recognize the impact of these diseases occurring outside of the United States and that we have to contribute to the efforts to control them. I think that those are things that are really, really important. I also think that the variants really make it clear that unless we take seriously support of other countries, we ourselves remain more vulnerable to these kinds of variants emerging in those environments. So it's really for selfish reasons, if not for the good of all, it's in the United States' best interest to really make significant contributions to the developing world in particular and to other countries throughout the world.
I can't say it better than how Dr. Morita just said it. Even if it's for selfish reasons, if we use that as the way to motivate people to action, that this unfettered, mutating virus, if it just is left like that, then a variant which can come by car, bus, cruise ship, plane, it'll be here and we won't even be protected against it with our vaccine that we may have hoarded because it's mutated enough that it's evaded all of our vaccine protection. So even if that's the message we need to use to encourage people while they're developing that take care of your neighbor attitude, we have to use all strategies.
And it's also a matter of fairness. Some people would say, from an ethical standpoint, justice. And it's the fairness of, how we distribute risks and benefits. We always think about, well, our city or our patient, our community, our city, our state, our country. But as pointed out, we're in a global economy, a global pandemic. And so how we distribute fairness across the world is definitely an ethical principle that we have to deal with. And what's good, though, is other countries have developed vaccines. I'm tickled by some of the names of them. Russia developed Sputnik 5. You know, I keep thinking of something orbiting around the world beeping, but Sputnik 5, China has a vaccine. We should be helping other countries to develop vaccines as well, which our engagement in the World Health Organization is really critical. Our re-engagement, I think, is really critical.
I want to go back to a theme that I guess the Biden and Harris administration had, which was build it back better. You know, as we think about sort of the pandemic really provides abundant evidence about structural prejudice. And so what do we do, I think, at various levels really to address some of these underlying determinants, which have caused, you know, the disproportionate impact that we've had, and sort of how do we build it back in a better way, our societies in a better way, and use this as an opportunity to address some of those structural factors.
There's a quote about that often is attributed to Rahm Emanuel, but I think actually goes back to Churchill, which is never let a serious crisis go to waste. And I think this is one of those crises that we should really take seriously. And there has been this awakening to the injustices and inequities that exist, the structural inequities that exist, and how they have allowed or led to this disproportionate impact. So when you look at, you know, people who are uninsured, people who have jobs that don't provide good pay or paid sick leave, poor housing or crowded housing conditions. These factors all played such a significant role in who was most seriously impacted by this pandemic, who was most likely to be hospitalized, who's most likely to die. And so there's this appreciation for that connection between these structural inequities and poor outcome and health, like there really has never been in before. But people have called this out, but there's not really been this acknowledgement of that connection. And so I think if we, in order for us to build back better, we really need to look at what has been revealed and take that to heart, and then change the systems that are in place to actually prevent this from happening again at the next pandemic, but also at baseline, because unless we address this at baseline, it's going to be the same thing all over again. I think to myself, this is kind of like Groundhog Day, because whether it's a heat wave, cold wave, a measles epidemic, H1N1, the people who are disproportionately impacted are these people who have suffered through these structural inequities for decades. But if it takes a public health emergency like this to really have us take it seriously and address these things and have minimum wage increase, assure universal health care access, provide better, secure, more safe and stable housing, then so be it. Let's go for it. Let's do it now.
I might add to that we also think about the inequities in terms of treatment by individuals, by government, the same government that is trying to implore people to take advantage of these life-saving resources. And just the confluence of this pandemic with the tragic public murder of George Floyd, I think, has reignited that same issue, which is just disparities and inequity. And so we have to address all of it. I am excited by that movement that was, reignited, if you will. And when we think about the numbers of people that participated worldwide in protests, the majority of them not being from minority status, there is hope that some of these issues, the inequity is seen as something that is all of our problem and that we all have a stake in addressing. So I think there's still hope and there's light, and hopefully we won't lose that momentum as we're continuing to fight the COVID pandemic.
I would maybe just add, it's part of why, as a public health physician, heading the Community Foundation Chicago, we have put closing the racial and ethnic wealth gap as our highest priority. We've got the largest life expectancy gap of any city in the nation. And if you look at the factors that are driving that, yes, healthcare, as we know, makes a difference, and access to health services makes a difference, but it's, your ability to feed your family, its ability to have a safe neighborhood, get a decent education, all of these other factors. And we've got this, wide and widening economic inequity, and COVID has laid that bare, and it has increased it. And so, I think to everybody's point, this integration of these issues is where we're going to really get the greatest impact. And I'm happy to see that the Biden administration has put, the COVID pandemic, economic equity, and racial justice as the top three, along with climate change. And if all of those things can be integrated and interwoven, then I think we will see the kind of impact that we want to see on health as well, and health disparities.
Great, that's awesome. I want to sort of go a little bit local. I think we've also seen instances where local health departments have tried to prioritize equity in communities of color. And for example, in Dallas, I think the health department wanted to prioritize vaccine communities of color, and the state came back, as I understand it, and cut their vaccine in half. But sort of, how do we deal with this sort of tension where at the local level, folks may be wanting to do things, and then there's this pullback? Sort of thoughts in terms of strategies that one could undertake when things like this happen, when you're trying to take an equitable lens and then the system pulls back on us.
I guess maybe I'll jump in, but then others please chime in as well. That is a challenge in and of itself if you're trying to make a policy change and then you're thwarted by a higher up governmental entity. But I also think that prioritization was just one part of an equitable vaccine distribution program. It's not the only way to ensure that a vaccine program is equitable. And so while that may have been thwarted, what Helene had pointed out and others have mentioned is that there has been some work that's done at state and local levels, and then also in terms of prioritization using social vulnerability indices. So you don't necessarily have to just, if there's a problem with focusing in on racial and ethnic groups, you can also get to more vulnerable populations using different kinds of indices that may not cause as much of an uproar or pushback as others. But the other thing is just making sure that the vaccines are located in geographic areas that are accessible, working with federally qualified health centers like Lee's that actually are embedded within communities and serving the most vulnerable populations and have trust and experience with these populations so they can actually reach them very efficiently. There's a system kinds of operationalization that can actually happen that can overcome, even if you're thwarted at the policy level, you can operationalize in a way that will adjust and support a more equitable kind of response.
Yeah, yesterday the Biden administration announced, and I'm sure there's a lot more work that needs to be done with actually figuring this out, that federally qualified health centers could receive direct shipment of vaccine right to the communities. And I know there's a lot of layers of this, and of course we love working with our health departments too. But that is a way to promote addressing health inequities and hardwired inequities that have been hardwired into communities for many years, because the bricks and mortars of community health centers there's something like 7,000 community health center sites around the country, and they are all in very high need areas. So it's a way of targeting directly. And I think it's a good way, and we need other approaches too. And also they are trusted centers as well in terms of perhaps vaccine acceptance and some of the challenges that we've all been talking about in terms of vaccine acceptance. But certainly exciting to hear that, and more to come to see how we'll actually implement that. And of course, always collaborating with our health departments as well.
I think the other Oh, sorry.
No, go ahead. Okay, go ahead.
I was going to say, I think another thing, and this is something, and, I look at Julie, when she was health commissioner here, I know they did a lot of this. How are we working with communities themselves? Because I think when something like what happened in Dallas happened, and I don't know enough about the situation to opine about that particular one, but when community health, when departments of public health are linked with communities and work with communities, communities will work on your behalf. And I think all of us need to work on how are we building those coalitions? How are we thinking about our role in advocacy as well as the work that we do? And I think building these kinds of coalition, particularly with the communities that are most affected, oftentimes can be your most valuable way of turning some of these things around. I also think, and I again can't help but be proud of our public health officials and Dr. Morita when she was commissioner, Dr. Awadi now, and Dr. Ezike. It does matter who's in leadership. And I think that when you have strong leaders, things do happen. And so I think we've got to think about this from the long game. We have to be strategic about it. How do we build our networks as public health people? How are we thinking about our relationship to community? And how are we really looking at who we put in positions and how we support them so that they can be as effective as possible?
No, your comment about creating that coalition and when sort of you might take the leadership role as a health department versus when a community group in terms of advocating, I think is really important. Lee, I wonder if you might talk a little bit about some of the work that you're doing with your FQHC, particularly around sort of, impact providing vaccine for essential workers, and sort of, are there things you're doing in terms of providing access to vaccine for essential workers, et cetera? What does that look like as you're doing your work, and some of the work that's happening within your clinical enterprise around providing vaccine in your community? You're in those communities in the city that are, highly burdened by COVID.
Well, yes, we are. And I think back all the way till March and February, March last year, almost a year ago. And, we've definitely come a long way, and to be able to be in the position to be ramping up with vaccine is almost like a dream come true. And that is on the base data that we were just looking at this yesterday, that we're estimating that we have 80,000 patients at Erie Family Health. About 40,000 of them are adults, which have been mostly impacted by COVID-19. And we estimate that at least 1 out of every 10 of our adult patients was actually sick with COVID-19, actually ill with COVID-19, with symptoms, and we took care of them. That doesn't count people who got tested elsewhere, they never felt sick, but really got a diagnosis in their chart. And that is really earth-shattering. And when 10% of a patient population has something and needs to seek care, that's why we've seen such overwhelming, stress on the healthcare system. And then you connect that with, ramping up vaccine. And I think the framework of 1A and 1B has been very helpful. And also at the community level, we're trusting, especially when we get to our essential workers who are in 1B, we're trusting the honor system quite a bit, which is really interesting at the community level. We're trusting our grocery store workers that they're grocery store workers, and that they're transportation workers, and that they're early childhood caregivers and teachers and food packing workers. And for the most part, and this brings me back to another ethical principle, which is tell the truth and how things start to work out. But I think at the community level, we are working with partners, our health departments, to figure out how to get the vaccines into the arms of most people and figuring out ways to ramp that up. And there's so many efforts going on right now. They're really now focused on that 1B, and we're making progress there. But I think we do have a quite a long way to go. And but I think steady progress is being made, and it really gives me a lot of confidence that we'll be able to get there.
Do others just want to comment sort of about sort of prioritizing or other things around essential workers? I'm thinking about sort of what's happened here in the city with Chicago Teachers Union. It looks like schools will be coming back later this week, which is awesome. But sort of how do we prioritize, between teachers, grocery store workers, et cetera, but sort of thoughts about that from the group?
No, as a state health official, I was so grateful to the work that Dr. Gale and people with the National Academies of Medicine, what the Advisory Committee on Immunization Practices did, because they really did the heavy lift for us. No one really wants to be in the game of picking winners and losers, who gets, who's first, who's second, who deserves, who doesn't deserve, who deserves. I mean, we all know that everybody needs, deserves, wants this precious potentially life-saving resource. And so trying to, assign everybody a number and say, line up, is not as easy as saying, line up, and if the person is taller, then you go behind them. So it's been just wonderful that there's so much work that was done on it. And so then we could work with this wonderful framework, this wonderful document to start with, and then just make the most minor tweaks, very, very unique to, the Illinois landscape. But it was quite a task, and they did a phenomenal job. And I think that as a whole, people they get it. They're like, oh yeah, the people who would take care of us in the hospital, you need them. Okay. Oh, all these people that have formed like 30-40% of all the deaths in the long-term care, and the people. Yeah. So it really, it really was helpful to have that framework and to be able to stand on that, because if we just made it up on ourselves, I mean, we're still getting, well, what about this? What about this? We got this, and there's no winning, because that you need it too. You need it too. So great work was done by those organizations, and we've been able to stand on it.
Yeah, I think the CDC and the National Academies did an incredible job with their prioritization scheme. They're elegant because you can see the rationale, the justification, the principles that were used. They were just beautifully done. The challenge, I think, is when the officials throughout the nation made decisions to vary from the prioritization recommendations. Because what happened with that, and the intent was all good, I think the intentions have all been good by everyone, is that they just basically opened it up to a lot more people than the supply can actually support. And so there was this expectation that the supply would actually meet this recommendation, and it was never going to be able to do that. And so there's just this unrealistic expectation in terms of the vaccine supply. And so it does require people to kind of step back a little bit and say, even though I'm eligible, am I at the highest risk right now? And so it puts it on the individual to make that kind of determination. I'm eligible, but I'm really not the highest risk. So I can work from home, and I can wear a mask, and I can order groceries. I don't have to go to the grocery store. It really puts it on the individual. And so I think there was a bit of a breakdown at that point, and that's unfortunate. But I also feel like there will be enough vaccine, and that's a really important message to everyone. It's that we're not saying that you can't have this vaccine. There will be enough for vaccine for everyone to get it. And so it's a matter of reflecting, self-reflection, and understanding your own risk and accepting, okay, these other people have a greater risk. Let them go forward and get it, and I'll wait until I'm eligible and others, and this vaccine is actually accessible and available to me. So I think it's as elegant and as a fantastic a job as the National Academies did and the CDC did. It's unfortunate that there was this broadening so quickly, and then this unrealistic expectation the supply was adequate to meet the recommendation.
And I would also just say, I think that it was unfortunate that we didn't have the kind of national leadership that would have been helpful helpful to guide this. One of the other kind of lessons of the importance of having strong national leadership, so that that people weren't left to on their own. And I think states, to a large degree, were often left to their own. And so, I am happy to see that there is now a stronger commitment to a national response, because I think that is critically important at a time like this.
I'm gonna sort of got 20 questions, so we'll see sort of how many of these we can get to, but we've got a lot, and I want to encourage people in the audience to also sort of, if you have questions, put them in the question and answer box, and we'll try to get to them. So one of the questions is, once we get to the general public, how should we identify, verify those who have, underlying medical conditions, or what should we do at that point? Thoughts from the group?
I'll reflect back on H1N1, which was a decade ago, and a much more simple and less complex response. We never asked for people to come with a documentation or verification or certification of underlying health conditions or eligibility to meet eligibility criteria, because it was a matter of feasibility. If the goal is really to vaccinate and get people in and out as quickly as possible, and especially in the setting where we have high transmission rates and disease circulating, you don't want people going around and dealing with those kinds of things. And we don't want extra barriers on people in terms of preventing them from getting vaccination. And so it does really become an honor system in terms of people self-disclosing, justifying their eligibility, et cetera. And so, I've had, because of my work on the advisory board, I've had an opportunity to talk to a lot of other health officials throughout the nation, and most of them are not requiring certification or verification of their eligibility for the vaccines, just because of the logistical concerns, and also the concern that it would become a barrier to vaccination.
I think it goes back to one of the principles that Dr. Francis mentioned earlier about truth. And I think, right, we expect people to tell the truth and be honest. And I think you could say the same thing about essential workers as well. Sort of
and to add to that, we do at the practice level, at the community level, community health centers, health departments, and medical, healthcare systems, we do have, big data sets, and we can always generate lists and proactively send texts and phone calls, and we can identify those people who are at higher risk and proactively call them in and try and raise them from the general population, which of course is the other way of doing it. And now, even seeing, some people are using artificial intelligence to do that same thing, but to really try and predict ahead of time who is going to be the higher risk. And then you call those people in and use machine learning, which I'd love to see more of that. But it's what people say and we believe them, which is fantastic, and also what we can proactively do as well.
Another question I have is thoughts on, as we roll from one phase to the next, and we now have the variants that are coming to the US, potential bottlenecks, and sort of how do we deal with that, right? Because we don't have sufficient amount of vaccine to meet the demand, and sort of, I guess their question is really about sort of, do we continue to do two shots of vaccine or immunize twice, or do we sort of move to where we just get everyone done once, vaccinated once, and then sort of delay the second vaccine? People's thoughts on that?
I can jump in, I guess. There's a mixed opinion if you talk to medical experts about the 2-dose series. But what I would say is the federal position and the CDC position, NIH position, is based on what FDA has actually approved the vaccines. So the current Pfizer and Moderna vaccines are both licensed for 2 doses. Pfizer separated by 3 weeks, Moderna separated by 4 weeks. And that's where the efficacy data are available, and so what they're based on. And so because of that, the CDC, the FDA, federal agencies are recommending that people stick to those schedules. I think what is available also though is CDC guidance, which is based on not just FDA licensure, but also based on general practices, immunization practices, best practices, subject or expert opinion, and other data that are available that say that if someone can't actually get vaccinated within that 3 or 4 week period of time, they can be vaccinated up to 6 weeks later. And that is a standard practice with most all childhood vaccines. Basically, you don't want to give one of those vaccines too early, but you can definitely give it later. And so based on that experience and the expert opinion, the recommendation stands for optimally vaccine is given with the 3 and 4 week period of time, but you can delay, or you don't delay it on purpose, but you can vaccinate and not have to restart the series if it's given later. I think the other thing to keep in mind as it relates to the variants is that we also have other tools to prevent disease transmission, and we shouldn't forget about those when we're talking about the vaccine. So we know that mask wearing works. In fact, there's a good study that was just released today by CDC related to how best to wear a mask to prevent transmission. So adherence to good mask wearing practices, social distancing, avoiding crowds, good hand washing, these are things that we know will actually work. And while we're trying to get the population vaccinated and the variants are of concern, continuing to do these other activities just remains ever more important.
I think it's also important to remember more vaccines are coming down the pike. I think Johnson & Johnson they have applied for EUA, and I think authorization should be coming soon if it hasn't come already. So that is a 1-dose vaccine. So I think that's important for us to keep in mind. Hopefully there'll be more vaccines applied. Let me go through a couple of other questions here. One of the challenges we've seen in the prioritization of COVID-19 responses is the assumption that children are less impacted. But emerging evidence suggests that this may only be partially true, despite advocacy, child and youth. So I guess your thoughts about sort of when vaccine might be available for younger age populations. I know Pfizer is doing a trial right now that's looking at 12 to 16-year-olds, but sort of when things like that might be available.
Yeah, we always wait till we have the science and the studies to back up, changes and lowering that age. So we know that there's I think they've already recruited or already in the trials for down to 12 for Pfizer. I know, I think AstraZeneca might have some with some pediatric population. So we're going to continually be learning more about these vaccines, whether it's, how long the optimal spacing for the vaccine doses versus do you need 1 dose versus 2, is 1 enough? And so I think by the end of this, by the second half of the year, we probably will have information that will allow us with some vaccines to start vaccinating the pediatric population. But obviously we'll wait, we'll wait till that authorization comes through so that we can act in line with the FDA and any ACIP guidance that follows it.
Another question we have is, I have been in conversations with people who are trying to figure out how to jump the vaccine line. Your thoughts about sort of how to have honest conversations with people about sort of why they should wait.
I'll start.
Yeah, I mean,
We talked on this a little bit because we've talked about truth and equity and waiting our turn, but what I'm actually seeing a good amount is that because and again I want to attribute it to this traumatic mass casualty event that we have all endured together, that people maybe are acting not at their best selves because they are so traumatized. And so maybe a year and a half ago, if you presented this theoretically, people would say, yeah, I'm not as much risk. I'm working from home. But after a year of, postpone your wedding and don't go to a restaurant and don't see your kids play sports, people are in a different place. And now it's kind of like, I just want this at all costs. And so there is quite a bit of this. And so when we were thinking about, oh, do you need paperwork? Do you need to certify that you are where you are? You'd like to say no, but we have seen that, people are so desperate for this resource that they are willing to lie. And people have said the lengths that they've gone through, and knowing whether a place will be doing any verification or not, they've identified those spots. So it may mean that as you progress through, you have to assess who actually is getting vaccinated and adjust accordingly in some cases. And I know I've heard from some of my local health departments that has unfortunately been required.
And I would just add to that. I mean, I do think one of the things that we are lacking, and I know it is in development, is a national campaign, an education campaign. It was one of the recommendations our study. In fact, 3 of our recommendations, sure people have the right information to make the right choices. And I think, having some core information that helps to frame this for everyone, I think will be very helpful. And so, I hope that we will get to the point where we do have that kind of the information bar, helping to start shaping people's thinking, shaping people's behavior, and I use the example of this SoulCycle instructor who said she was an educator, jumped the line, and the negative reaction that she got. And so I think that there's enough of that public accountability that is going to start happening as people start thinking about this more. So I do think education helps, information helps. We can start shifting norms in ways that I think can be very helpful.
I think, Helene, that was sorely missing in the first part of this pandemic in terms of clear and consistent communication and expectations. And what we're seeing play out in this next wave of the response is a much more consistent and clear messaging effort from a federal level, which then helps at the state and local level. I can remember sitting on, I don't know how many countless CDC conference calls, whether it was related to Ebola or measles or Zika, listening to the CDC messaging and then translating that here in Chicago just so that others could actually hear it and it was consistent. And then people were much more likely to comply and adhere just because they were hearing the same thing pretty consistently. So I think that's really important.
And just to add a fine point to it, I mean, all of us listening to this understand why the phases make sense. But we can't assume that the general population understands risk frameworks and all the rest of it. And so, I think that most people with the right information will do the right thing. We've got to make sure we get the information out.
Good point. Thanks. Another question is about the Medicaid population. And Arvin Goyle asks, the Medicaid population we serve are among the most vulnerable with multiple disparities, chronic conditions, and including less Wi-Fi access, which makes them vulnerable with, vaccine, trying to schedule vaccine, et cetera. What are some of the outreach to people who are vulnerable that we need to have? And I think maybe we think about this sort of at the national, state, and local level as well. But think about outreach to vulnerable populations. This gets at the issue of vaccine hesitancy as part of this as well.
So the CDC is actually working on supporting or directing resources to a number of community-based organizations and efforts that are focused on community workers getting into community to help people make appointments for vaccine, educating them, sharing information with them so they can actually access the vaccines more easily and more accessible, make it more accessible for them overall. So they're tapping into the REACH initiatives, which are more chronic disease oriented, but they did that with flu vaccine, and they're continuing to fund organizations through that mechanism for now COVID vaccine, and they're expanding out beyond that to actually fund other community-based organizations. And there's a number of different local efforts that are going on as well. I sit on the New Jersey Department of Health advisory board, and they have community health workers who are geared up to do engagement in communities for this population in particular, and they are ramping up to actually go out to help facilitate vaccination in those communities. And I know that Chicago is also doing something like that with their Protect Chicago campaign and efforts, where they're relying on community-based organizations who are trusted sources within communities to help people register for vaccines and also to access the vaccines themselves. So there's a number of efforts at a national level as well as at a state and local level to actually kind of help reach these high-risk communities.
I was actually on an email earlier today with some of the UIC School of Public Health students, where they were reaching out to UI Health to sort of help to sort of call patients and help them navigate through this.
In addition to reaching out to them, we also have to make sure that they have the protected time to be off from work without suffering a financial loss, to be able to go and wait and get that vaccine. You know, there's time of transport, there's time to get it done, and then time to get back to work. And so somebody having to choose between, I might get in trouble or sanctioned or fired from not showing up because I'm trying to get this life-saving resources, versus staying on the job and taking my risks being unvaccinated, like that's an untenable choice that many people have.
A couple of thoughts from a community standpoint, and I totally agree with what Dr. Ezike just said. I think, number one, I think we learned a lot about the digital divide from telehealth.
Yeah.
And those of us in primary care that had to do that rapid pivot to telehealth, and then just kind of scratching and crawling and trying to get those telehealth versus telephone rates up to 30–40% of visits so that we could really see our patients and interact with them. Well, the same is true as we try and interact with scheduling patients for COVID vaccine. We live in a society where people want something now. They want same day appointment for their cold before COVID, or they want to go through the drive-through and get their, hamburger now. And so we have, with a limited supply of vaccine, we can't be so open with that. Maybe at some point we will get to that. The other thing that came to mind is that I think our local health department, our state health department, we've been very lucky here in Illinois and Chicago area. They have really masterfully communicated early and often, and have helped kind of balance out what was happening from the federal level. And I think we're ready to go to the next level, because we know that people, from a marketing standpoint, if you want someone to buy a car or a candy bar or whatever it is, you have to keep communicating to them like 7 different ways. Radio, TV, we had Instagram live event last week, social media, billboards. I mean, the more people hear, and then they finally start to get it. And that's just like something we can take from our marketing colleagues and take that into public health. It's not like you hear it once and then you know exactly what to do. And I think we really have learned about that in the pandemic.
Another question is, I received my vaccination through my employer, UIC. I don't recall being asked about socio-demographic information. I don't know if that information is being captured. So is data being collected for agencies so they know the distribution by socioeconomic factors, race, ethnicity, et cetera?
So at every dose of vaccine that's administered is supposed to be reported into the state immunization registry, and along with name, date of birth, address, race, ethnicity data is required as well. So we don't have specific socioeconomic, but we have the zip code. And so that potentially could be used as a proxy. We know some of the zip codes or the areas that we would say are the more vulnerable, referencing back to Dr. Morita mentioning about the social vulnerability indices. So we do have that information for the few cases. Actually, I think it was about 25 to 30% of reports of immunizations that did not have that information, we have done an aggressive, matching system with other databases to try to get that information. So really now we are well over 90% with that information, at least the race and ethnicity data.
And we're better than much of the nation because we know that, yeah, right, exactly, that race, ethnicity data is lacking up to this point. And, it's a huge issue because it's hard when we think about if we're trying to target communities that have been most impacted and we don't have the data to be able to do that and see how well we're doing, we're flying blind. So, it's a big area of need, I think.
Yeah, I noted in the MMWR that came out a couple of weeks ago from CDC, something like 50% of the data on race ethnicity was missing. I mean, that's a huge misfortune. So good. Another person asked, are we risking perpetuating inequities if we distribute the Johnson vaccine and granted EUA in rural and inner city communities because of, doesn't need deep freeze, et cetera. Yet the efficacy is 75% versus Moderna and Pfizer, where the efficacy is 95%.
I'll start with this. I think here's where there's an important messaging piece, which if we don't message this correctly, we were going to have that myth be propagated and people refuse this life-saving resource. We have to think about where we are today versus where we were even 2 months, 3 months, 4 months ago. And remember that, this newer vaccine that's up for authorization, is in a different setting than Pfizer and Moderna. The J&J vaccine was tested, overseas as well as here, where you have these larger percentage of variants. And so when you're looking at that efficacy, comparing it to places, to the Pfizer and Moderna, where there were lower levels of that, and you're not comparing apples to apples. We don't actually know how Pfizer and Moderna would stack up if the trial started today and you were putting it in the setting of in South Africa or places where the variant was circulating. So we have to be super careful. In many ways, this J&J vaccine is like the thing, like that's the one. We know that some people just have an aversion to needles, and the thought of having one instead of two is a big deal. The fact that you can get it easily to people without the risk of waste, where there could have been temperature diversions and excursions that could have maybe rendered the vaccine, ineffective. I mean, this is really a wonderful, potentially a wonderful resource. And so we have to be so careful about the messaging that we don't, drown it before it even comes to surface.
Yeah, this is where, helping people understand the difference between individual and population. Because if we're able to get more people vaccinated by having the J&J vaccine, it is going to help us as individuals as well by having, higher rates of vaccination. And, if we think back, we would have been happy to have a 50% efficacious vaccine. Now we're talking about one that's probably 70+% effective. I mean, like you said, this is something to celebrate. This is not something to look down our noses at. This is something to celebrate.
Yeah, I would agree with that. I'd add that, first of all, the data that people are talking about now too is based on what came out of a press release from the manufacturers. And so FDA is still yet to do their evaluation. And likely the results will be very similar because that's what happened with Pfizer. That's what happened with Moderna. The results were similar. But I always wait to pass judgment on a vaccine until I see what FDA actually says about the results and the analysis that they do themselves. And that should be coming by the end of this month. But one of the things that was kind of a subtext within the press release was that when they looked at efficacy in terms of prevention of hospitalization and serious disease, there were high efficacy. It was 85%. So while I'm still reserving my time to pass judgment until after the FDA approves, I'm looking at that particular measure of effectiveness because I think that's going to be really critical, because that is what we're really trying to do, is prevent serious disease, hospitalization, and death. And if that efficacy is at 85%, that's pretty phenomenal.
I think the other outstanding aspect about the FDA is the fact that all of their data is up on the web, so everyone can look at it. They do their own independent analysis as well. But it's just, I think that level of transparency. Don Ziegler asked the question, hesitancy is one thing, but how do we address anti-vaxxers' influence, particularly in vulnerable populations?
I think the pediatricians should answer that one.
I think all three of us are pediatric trained, right? But, well, I'll give my thoughts for, I think in this, if I were to prioritize where I would put my time, it would be with people who are lacking information, who are skeptical, but who information and science-based evidence will probably help them make decisions. And I think in the scheme of things, there are clearly a group of people who, for whatever set of reasons, don't believe in vaccines. It's a relatively small group of people who are absolutely dead set against that. I'm much more worried about, are we getting the right information out to people who are on the fence, but who don't have any, basic disbelief about vaccination. And so I just think that's where we need to continue to put our focus.
Yeah, absolutely. I was divided into the, there are the not ever, like they're just, you might not want to spend too much time, not ever. And then there's like the not sure, and then the not first, and so we've seen a lot of people who were offered it first. I know we had rates in some long-term care facilities in some state, congregate settings where the uptake by the residents was 80-90%, and the uptake by the staff was 18%, 20%, 25%. But now millions, tens of millions of people, in this country, hundreds million around the world, and now people are like, oh, when you come back to give some other people, that second dose, and then they're like, wait a minute, I've changed my mind, and so there's just a lot of like, I don't want to be first, and then there are some people that are not sure, and so having the town halls and being able to ask a medical provider their specific questions, some of the circulating facts that are not really facts, not true facts, at least being able to have somebody talk about those, go through that, have trusted messengers share the message. Those numbers are really climbing. They're really climbing. And so there is a lot of opportunity. Everybody is not in the same boat that you're just not going to be able to move the needle. There are most people you can, no coercion, but just full communication so that people can make the best decision for themselves with appropriate facts.
Isn't it amazing how even in our highly electronic communicative society, that what really rises to the forefront here is person-to-person communication from one person to another, even a lay person. Did you get it? Oh, I got it. How was it? Oh, my arm was a little sore. Oh, well, how was the second one? Oh, it was a little sore. I had a little chills. I'm fine. I'm standing right here. Okay, I'm going to get it too. It's almost like, in the olden days where, the horse would gallop, with the rider from village to village saying, the vaccine is coming, the vaccine is coming. It's going to be terrible. And then the next horse comes along, the vaccine is coming, the vaccine is coming. It's not so bad. And then the next horse comes in, the vaccine is coming. It's actually just fine. And then people start to, they start to accept it. And, but you're right. I mean, that 15% or whatever it is that are just like, I'm not going to get it, let's concentrate on the people who are in the middle, who we can sway, and then we'll get enough immunity in our villages that we need to have.
Yeah, what I would add, I think I totally agree with that, and I also think that the national academies did a great job with their recommendations, because one of the things that they said was how critical it is for two-way communication. But it's not just one way. This is the fact accept this information, but there's actually, what's critical is this two-way information so that we actually hear what the questions are, answer the questions, what is the information that's needed, provide the information that's needed, who do you want to hear from, have the right people conveying the information. So it's got to be a two-way communication, and the National Academies Report really laid that out specifically as a priority need to address hesitancy and to ensure a more equitable vaccine distribution.
Well, I want to thank all of you. I'm going to give you one last opportunity to think about sort of what are the additional things, you know, that you think we should also be thinking about, or sort of going back to that question I asked Dr. Dale at the beginning. Looking back, are there things you think we should do differently or that we really need to amplify? And it seems to me this national campaign is one of them, and that is coming. But are there other things that you think we need to be doing either at the state level or at the national level, et cetera, as we continue to roll this out?
Oh, I'll just say, you know, and I say this every time we get into this situation, we got to strengthen our public health system, and we got to believe in it, and we got to not wait to the next crisis. I mean, you know, I hate using war analogies, but nobody would ever accept the fact that we take our army out in between anytime we need them. We believe that we need to have a defense prepared, ready, and in the best shape possible. We need to do the same thing for our public health infrastructure. And so I just think, you know, it's not specific to COVID, but we just, in between, you know, crises, we kind of let our guard down. And if we believe that we need this defense, and that, you know, what is more likely to take us out these days are biologic, not a, you know, not a military crisis, then we've got to strengthen our public health infrastructure as if our life depends on it, because it does.
Any other
health promotion, you know, as part of that public health infrastructure is really making sure that from, you know, kindergarten, you know, little kids know by the time they're 2, they know when they head into that clinic that there's somebody about to put some needles in them. But if we can, you know, in preschool and kindergarten, start explaining very, very intentionally about what those needles are that they're putting in their arm, and what are these, what is polio, and show them pictures of kids maybe who look like them, who maybe were in braces because they had polio. So they're doing double Dutch, or couldn't do double Dutch because they had these braces on, but you don't have that, and haven't seen anybody with that because you got those jabs, you got those injections that protected you. You know, we know that the vaccines do such a good job that people have a complete amnesia for any of the diseases that once existed. And so making sure that people remember how good these vaccines are at making you forget about these diseases, so that you can have the appreciation and the reverence for these life-saving resources.
Good.
And I just, what comes to mind as a closing comment is I'm heartened by this discussion today, and I'm really glad that we could put ethics together with public health. It's just you know, so delightful to be able to do that. And you know, 6 months from now, as vaccines roll out more for COVID-19 and more of the population is vaccinated, and hopefully we're making major progress. I just have in the back of my mind, asthma has not gone away. Pregnant mommies, the babies are not waiting for COVID to be over. Diabetes has not yet been cured, and the list goes on and on and on. And luckily, flu is great this year. The masks work apparently, but these are the items and the things that we're going to be talking about maybe at this time next year. But let's cross our fingers and wish ourselves luck.
So I'm gonna, because I'm last, I'm gonna say 2 things. First, very COVID specific. I don't want us to move forward and focus on speed of vaccination and at the expense of equity. That we really have to have an equitable vaccination program, and both can happen simultaneously. We can vaccinate quickly and we can do it equitably, but we have to put the right resources in the right places to make sure that it is an equitable response. So that's COVID specific. And then to follow up on what Lee said is, I think because of the if we address the structural inequities that have been laid bare by the pandemic, lack of housing, poor jobs, lots of jobs with poor pay or inadequate pay, lack of insurance, all these systemic issues, we will, if we can address those things, we can actually improve asthma, diabetes, prevent the next inequitable outcome of a pandemic. So it's really a matter of taking advantage of this opportunity that we know that these structural inequities are in place and we need to address them now. And so I'm hopeful that because of what's happened, if we don't take advantage of this opportunity, it will truly be a missed opportunity.
Equity is good public health.
Good. Thank you, everyone. This has been an amazing panel. Again, I want to thank Dr. Ezike, Francis, Morita, and Gail for just doing a great job. Special thank to Dan Swartzman and all of Dan's fans, because we wouldn't be here today without all of them. So again, thank you, everyone. I do want to quickly mention to our folks in the audience that on April 8th, we will have our annual alumni celebration, and there are some great awardees there. You can go to publichealth.uyc.edu/AAC for more details about that. Thank you, everyone. This has been a great panel. Appreciate everyone. Have a good evening. Bye-bye.